Good morning. I welcome you all for the Young Physicians Forum. This is going to be the last Young Physician Forum for the year 2021. And without much delay, I would like to invite the first speaker. We are having two presentations today. The first speaker is going to be Dr. Sunantha Niruban. She is the Senior Registrar in Gastroenterology and Hepatology, National Hospitals of Sri Lanka. And she will be talking to us on the liver transplantation, pre-transplant workup, and optimization of the patient. Over to you, Sunantha.
Good afternoon to you all. Thank you, Chairperson, sir, for the introduction. First of all, let me thank the Ceylon College of Physicians for giving me this opportunity to deliver a talk. So what I would like to do in next 25 minutes is to give you all a brief introduction to the liver transplantation and how the pre-transplantation workup has been carried out. And I would encourage you all to refer this liver transplantation patient workup for the patient who are in need of this highly life-saving surgery. So outline of my presentation is the introduction to the liver transplantation. What are the indications and contraindication to the liver transplantation? How to choose a patient? When are we going to refer? And how to do the evaluation and workup? What are the problems we are facing while on the waiting list and how to manage those problems and further optimization? So a brief introduction to the liver transplantation is it has been there for more than 35 years, and first liver transplantation ever done in 1963 by Dr. Thomas Tars. He is the pioneer of the liver transplantation. Thereafter, there are number of liver transplantation has been increased worldwide, and first liver transplantation in Sri Lanka done in 2010 by Professor M. Vijayaratne and his team at NHSL. And we know that recently successful pediatric liver transplantation done at Ragama Teaching Hospital in 2020. So it is an ultimate treatment for the many end-stage liver diseases, acute liver failure conditions, and there are other non-liver failure indications as well. So it can be either way of cadaveric liver transplantation or live liver donor transplantation. There are more than 5,000 liver transplantation has been done annually in Europe, and survival rate at expected to be 1 year is at 96%, 5 years is 80%, and still 10 years it is 71%. Despite this successful outcome, only a fragmentation of patients are referring for the liver transplantation. We know nowhere in the world there are enough organs to transplant each and every patients who are in need. That means there's a waiting list. So the death while on waiting list is approximately 20%. The success of liver transplantation has been dramatically improved so far over the 35 years, and this success is due to several advances in new immunosuppressive agents, new preservation solutions, improved surgical techniques, and moreover the improved patient optimization and early diagnosis and management in the post-liver transplantation. So this graph clearly illustrates how the 1 year survival rate has been improved from where it was 34% at the beginning, and now we are in 86%. Then who are the candidates for the liver transplantation? It is indicated in end-stage liver disease, acute liver failure conditions, and some other non-liver failure indications such as hepatocellular carcinoma. So the main principles or the essence of the liver transplantation is if the liver transplantation, if the expected survival of the patient without liver transplantation is less than 1 year, or the quality of life is unacceptable as a result of liver disease with no other medical or surgical alternatives, then those are the ideal candidates. So in other words, it should be considered in any patients with end-stage liver disease. If the liver transplantation would extend the life beyond that predicted by the natural history, or if the liver transplantation is improve the quality of life, then those are the ideal patients. Then we move on to the indication. So more than 90% of the liver transplantation are for the end-stage liver disease, and there are few remaining causes. It can be for the 9% for the acute liver failure conditions, and there are other less common causes. So among the acute liver failure, we know it is a complex of syndrome which the features are mainly the hepatic encephalopathy, coagulopathy, and jaundice, which occurring in a patient with less than 6 months of duration without any background history of chronic liver cell disease. So these are the common etiology. Among those, acetaminophen overdose and the acute viral hepatitis are the common. Apart from that, drugs or toxin, autoimmune hepatitis, Wilson disease, and ischemic hepatitis are the rest of the causes. So the managing the acute liver failure patients after establishing the diagnosis is really challenging. So we don't know who are the patients will improve with the treatment or who are the patient will end up in poor outcome. So based on the certain criteria features, we should refer those patients to the liver transplantation unit. So that is based on the King's College of criteria. So if the patient is having paracetamol induced acute liver failure cases, if the arterial pH is less than 7.3, where INR more than 3, oliguria, altered level of consciousness, hypoglycemia, elevated arterial lactate, which is unresponsive to fluid resuscitation. So those are the common criteric features to refer to the liver transplantation unit. If the non-paracetamol in these cases, pH less than 7.3, INR more than 1.8, oliguric renal failure, or hyponatremia with less than 130, encephalopathy, hypoglycemia, metabolic acidosis, and serum bilirubin more than 300. So ideal settings, patient should be transferred to the liver transplantation unit before the encephalopathy appears. So these are the common chronic liver disease features, etiology. So among those, alcohol and non-alcoholic fatty liver disease are commonest in our settings. Apart from that, chronic viral hepatitis, autoimmune condition, genetic and congenital causes are there. Having said that, they themselves do not warrant liver transplantation. So we know it's a spectrum of disease which go through the compensated cirrhosis and move to the decompensated cirrhosis. If the patient is having compensated cirrhosis, they do not warrant the liver transplantation. But if they develop any complications or decompensated cirrhosis, then they need a liver transplantation. So I would like to focus you on to these two graphs. The first graph illustrates how the complications of the liver transplantation develop during the progression of the liver disease. The second graph clearly demonstrates the mean survival rate of patient with the cirrhosis is around 8 years. But if the patient develop any decompensated cirrhosis, their median survival drastically dropped to 1.6 years. So at this point, they need a liver transplantation. So what are the key consideration if you are dealing with a patient with a hepatic decompensation? So is a decompensation potentially reversible? I already mentioned the patient is having decompensated cirrhosis, they warrant a liver transplantation. But on the other hand, sometimes the decompensation may resolve with the treatment. If the patient alcoholic decompensation, sometimes with the absence of the therapy, they may improve. With the effective antiviral treatment, they may improve. And sometimes autoimmune hepatitis patient with the steroid treatment, they may improve. So decompensated cirrhosis, all the decompensated cirrhosis patient does not warrant a liver transplantation. But that doesn't mean we should start the evaluation workup for this patient. So if the patient have features of decompensation, we should start the evaluation workup. And if not reversible, is a patient suitable for the liver transplantation? Are there any contraindication to the liver transplantation? Sometimes if patient currently not suitable for the transplantation, but could a patient become suitable with the treatment or intervention? So these four are key consideration we should consider when we are dealing with the patient with decompensated cirrhosis. So we do have an objective scores to tell us who are the patient will need for liver transplantation. That is how urgently the liver transplantation is necessary. So that is based on the Child-Pugh score, and there are other Milden-Miltner score. Compared to the Child-Pugh score, the Milden-Miltner score have high predictive mortality, which is based on this bilirubin, INR, and creatinine. So this graph illustrates if the patient is having MEL score more than 15, they have a highest mortality risk if the liver transplantation has not undertaken. So while in the waiting list. So the MEL score 15 is a magical number. We should start the evaluation workup for the liver transplantation. But there are problems with the MEL score because we know if the patient developed any complications, the survival rate of the cirrhotic patients will drastically drop. So those complications do not directly encountered in the male score. And there can be variations in the creatinine, and because of the sarcopenia and poor nutrition, creatinine can be variable. So male score does not reflect the impact of all complications in cirrhosis. So that comes is the male exception. So these are the features: refractory ascites, refractory hepatic encephalopathy, recurrent variceal hemorrhage, hepatopulmonary syndrome. These are the common male exception. So the expert should know the male exception. So these patients should be given priority for the liver transplantation. What to do with a very high male score? That is debatable, because these patients have high transplant mortality and morbidity, and also significant high ICU stay. But having said that, the patient having severe alcoholic hepatitis and acute and chronic liver failure with a high male score, they can be considered as a candidate for the liver transplantation. But the researchers are showing that they have a survival benefit. There are other non-liver failure indications as well for the liver transplantation. These are the common persistent intractable pruritus, polycystic liver disease, hepatopulmonary syndrome, and other less common causes. And also hepatocellular carcinoma is also a male exception. We should give priority. So in UK, 25% of the liver transplantations are done for hepatocellular carcinoma. So initially the survival rate was very poor, but the recent days it is considerably acceptable survival rate if we are using the Milan criteria. So what is Milan criteria is, if the patient is having solitary hepatocellular carcinoma less than 5 cm, or 3 or less than 3 nodules with a diameter of less than 3 cm, they can undergo liver transplantation. Their survival rate is accepted. That is, 5-year survival rate is around 70%. But there are other teams also develop the expand this criteria, and they also show the accepted 5-year survival rate. So that is the UCSF criteria. Next, we move on to the contraindication. These contraindications are ever changing. That is dynamic. So previously thought of contraindications are now no more contraindication. In the current setting, these are the common contraindication. The patient is having severe pulmonary hypertension with the mean pulmonary artery pressure more than 45 is a contraindication. Untreated HIV. The patient is having treated HIV with good immunological response. Those can be considered. Alcohol addiction, hepatocellular carcinoma with extrahepatic metastasis, ongoing sepsis, and extrahepatic malignancies and anatomical abnormalities. The related contraindications are morbid obesity and non-adherence to the treatment, and neuroendocrine tumors, and especially the inadequate social support. There are no formal age limit for the contraindication, but it has been performed successfully in age more than 70 years. But these patients have a high comorbidity, so need to have an extensive evaluation with the multidisciplinary team. Then how are we going to further evaluate? So the process of liver transplantation should be checking the indication, contraindication, suitable timing. Then we need to manage the patient with the liver disease, manage the patient etiology, assess the complications, and continuous monitoring. And we need to screen for the diseases and other comorbidities, and ultimately further optimize with the vaccination. So this recipient will undergo the multidisciplinary team evaluation, which involves physician, hepatologist, intensivist, radiologist, pathologist, every multidisciplinary modality. So the importance is the good communication network between this all multidisciplinary team, and at the end of the day, what we want is to improve the quality of life and the life expectancy of the patient. So how to manage this patient, etiology and complication, I'm not going to deal with these two. How are you going to manage the comorbidities? So we know the dyslipidemia, diabetes is also common in the general population as like that. It is also prevalence in the transplant recipients as well. The hypertension is around 40%, 40 to 85%. Dyslipidemia around 40%. Diabetes 10 to 65%. With these, there's a cumulative risk of cardiovascular events, so that is around 25%. So everything should be managed as a general population with the lifestyle modification, and also we should the other further medical therapy, pharmacological therapy with the NACE inhibitor, statin, insulin, and these need to be continuous follow-up with the optimization. And obesity is also common in transplant recipient, which increases the risk of perioperative complications. So these also need to be monitored, and the patient should undergo lifestyle modification, and if patient is in a compensated cirrhosis, can undergo bariatric surgery or the medical therapies. So, end-stage liver disease patients are because of multi-system involvement, they may have a complications in each and every system. So, evaluation should be done by way of each and every system, and also infection screening, psychosocial assessment, and bone abnormalities. So, with regards to the infection screening, patients with cirrhosis are more prone to get infections because ongoing sepsis is an ideal contraindication. The patient should be screened for the bacterial, fungal, and viral infection. And if the patient is having, we need to screen for the latent tuberculosis as well. And moreover, the cytomegalovirus status also need to be determined. And in this setting, we need to screen for the COVID-19 as well. So there are no data says the end-stage liver disease patients have a high increased risk of COVID-19, but they have because we know the COVID-19 have a high preponderance to the ACE2 receptor side, which is common in the liver and the biliary system. So they may have an increased risk, so need to be screened. So HIV, hepatitis B, C, chest X-ray should be done. And those who are eligible for the liver transplantation, you need to screen the tuberculosis, urine culture, parasitological screening, VDRL, and also the MRSA and dentistic OMF referral. And depending on the certain epidemiological region, there are certain endemic infections. So we need to screen for that also. In our setup, especially malarial blood test should be done. In the respiratory function assessment, a lung function test and chest X-ray should be done in all patients. And we know there's a 10 to 17% of the hepatopulmonary syndrome in cirrhotic patients. So it should be screened either with the pulse oximetry, the bedside test. If there is less than 96%, need further evaluation with the other contrast to echocardiogram and lead. And also portopulmonary hypertension also common 2 to 8%. It should be screened by the echocardiography. And depending on the value, right ventricular systolic pressure more than 45, need to do the further cardiac catheterization studies. So those patients ideally treated with the vasodilators. With the vasodilator therapy, the patient is having mean pulmonary arterial pressure less than 35, then they can be considered as a candidate for the liver transplantation. More than 35 is a contraindication. Then cardiovascular assessment, because these patients have more cardiovascular abnormalities based because of the comorbidities, as well as cirrhotic cardiomyopathy, poor systolic and diastolic dysfunction. So need to undergo ECG and echocardiogram. And there are also data suggest that the patient, depending on the cardiac risk factors, further evaluation can be done by way of stress echocardiography and cardiac catheterization. If the patient found to have any significant coronary artery disease, they should undergo revascularization surgery before the transplantation. And the renal function, cirrhotic patients have a high, if the patient with the cirrhotic with the renal failure, high for increased risk of death. So hepatopulmonary syndrome is not a contraindication. If the patient is having renal impairment, they do undergo the liver and kidney transplantation. Then more important thing is a nutritional assessment, because cirrhotic end-stage liver disease patient, more than 95% of the patients are malnourished because of the poor intake, and also low palatability because of the low sodium and poor absorption. Those things will facilitate. And also nutritional status is hard to assess in cirrhotic patient because of the ascites, peripheral edema. We can't define the patient whether is malnourished or normal. And also what they found is malnutrition with the less than 18.5 BMI is associated with poor survival outcome. And on the other aspect, obesity also increasingly common, the NASH with the metabolic syndrome. So everything should be thoroughly evaluated. And it's also there is a sarcopenia because of the progressive deterioration of the muscle mass loss that is common in 70% of the decompensated CLCD. So ideal setting, it should be quantified with a CT, but each and every patient can't undergo CT. So there are other measurements, anthropometric measures by way of triceps skin fold thickness or mid-arm circumferences need to be evaluated. And there is another increasing contest is sarcopenic obesity. So 50% of the end-stage liver disease patients have sarcopenic obesity, where they have high fat mass with a low muscle mass. But here, so this sarcopenia is masked with the obesity. So ideally, the diagnosis is also difficult and management also difficult. We can't restrict the calorie in this patient, because if you are restricting the calorie, it will more ended up in sarcopenia. So everything should be clearly evaluated, and proper counseling and dietary assessment need. The assessment is also important, but anyway, the treatment is also difficult, challenging, whether the patient will improve or not. And also it should be supplemented with the nutritional multivitamin, calcium, zinc and magnesium. There is a role of branch chain amino acid as well, which improves the quality of life and prognosis. And all these factors will ended up in the frailty of this patient: malnutrition, sarcopenia, other comorbidities, and also with the ongoing severe chronic inflammation, progressive immobility, aging, all lead the patient to the frail. So this is common in transplant list, and this is a common reason for the delisting as well. It will associated with the longer hospital stay and increased hospitalization and high wait list mortality. And we also need to evaluate the anatomical variation. We need to assess the hepatic artery, biliary tree, and portal system by way of CT, contrast CT. So if the patient is having portal vein thrombosis, again, is not a contraindication. If the patient portal vein thrombosis extend to the mesenteric system, then it can be considered as a contraindication. And malignancy screening, depending on the age and risk factor, we need to screen colonoscopy, mammography, and pap smear. And also with the patient having additional risk factors such as alcohol, smoking, addiction, it should be evaluated with the pulmonary. We need to screen for the chest and ENT stomach cancers. And the patient is an elderly patient with the primary sclerosing cholangitis or IBD, need to screen with the colorectal carcinoma screening. But having said that, the treated cancer is not a contraindication if the patient undergone definite treatment of the cancer, and also the accepted tumor-free survival rate, those patients can be considered for the liver transplantation. And we also need to assess the psychosocial assessment of the patient, because this is more important for the post-liver transplantation care as well. And bone abnormalities, osteoporosis is common because there are additional risk factors such as female sex, lower BMI, tobacco use, nutritional poor nutrition, steroid use, hypogonadism. So all these will facilitate the patient to end up in osteoporosis. So it need to be evaluated with the DEXA scan. If the patient is having osteoporosis, need to treat it with the vitamin D, calcium, and bisphosphonates are also safe. After managing these, we put the patients on the waiting list, because we know there are a shortage of livers and there is a incompatibility with recipient blood group. So difficult to predict when are those patients going for a liver transplantation. So while in the waiting list, patient may have many potential risk, and that can be lead to multiple listings. Sometimes it lead to delisting as well. So what is our goal is to prevent waitlist mortality and dropout. So the risk and complications can be liver failure complications and also cardiovascular events. Patient may progress to hepatocellular carcinoma, poor nutrition. Sometimes patient may relapse with an alcohol on psychosocial issues. So these things are the complications, cardiovascular events already mentioned. So I'm not going to lead with these things. So among these alcohol relapse, what they found is 15 to 20% of the patient on wait list are relapsing the alcohol. So we need to monitor, and we need to refer to the appropriate addiction services. And more important thing is the counseling and other behavioral modification therapy. And psychological issues, because there is a fear of surgery, post-surgical fear, and also sometimes patient may have concurrent alcohol or drug abuse. So those patients have high rates of depression and anxiety. So this will lead to reduce pre-transplantation survival or reduce the quality of life of the patient. They will have a poor adaptive coping facilities and reduce the functionality. So all these things should be managed, should be identified and managed by way of educating the family. We need to have a good reassurance and psychotherapy and spiritual support. Then further optimizing the patient is by way of vaccination. We need to remain up to date with the immunization, hepatitis A and B, and pneumococcal, seasonal influenza, and diphtheria, pertussis, and tetanus. And nowadays COVID-19 vaccine as well, because there are no data suggests the immunogenicity of vaccine has not been fully described in this population, but vaccination has associated with the low risk of COVID-19 infection. So after done everything, we need to monitor this patient in the clinic. So these are the core concepts when we are dealing with the patient. So we need to avoid decompensation and complications of cirrhosis, and we need to have a surveillance with the hepatocellular carcinoma and sepsis evaluation, and important thing is the nutritional. So that comes to end of my presentation. So let me summarize what I have told just up to now. So listing of patients for the liver transplantation is only the first step in a long and difficult journey. While waiting, patient can experience many complications of chronic liver cell disease. The important thing is to prevent, recognize, and institute early treatment for complications. And management of the complications allow to optimize chances of patients reaching a desirable outcome. And we need to maintain the hope while ensuring an appropriate holistic approach. These are my references. Thank you for your patience. And I would be happy to answer any questions.
Thank you, Sunantha, for that wonderful lecture. And is anybody in the audience needs to ask any questions? Right. We received one question from the online audience. What are the parameters need to consider in patients with hepatopulmonary syndrome? Do all the patients with hepatopulmonary syndrome needs transplant?
Yeah, if the patient is having hepatopulmonary syndrome, they have a severe high mortality. So those patients should undergo liver transplantation. But if the patient, we need to first diagnose the hepatocellular syndrome, and if the patient is having per se, it's need a transplantation. There are not certain factors, so we need to identify it, and we go further workup with the liver transplantation evaluation.
Okay. Anyone else? I wonder whether Madam wants to ask any questions. Right. Anyway, are there any conditions, like say that, are there any conditions which can recur in the transplant liver? That we know there are so many conditions after the transplant of the kidney, the conditions can recur. So what are the conditions which can give rise to cirrhosis of the liver after the liver transplant also?
Yeah, if we are doing the transplantation for the infective causes, hepatitis B and C, so those we are not dealing with the proper immunological prophylaxis, so those patients can recover. It can be recur in the transplantation, and also the hepatocellular carcinoma. So those also can be ended up in retransplantation. And some other usually the genetic causes also can recur in the liver transplant most of it.
Yeah.
And those are the common causes for the retransplantation as well, the infective cause.
Yeah. Thank you, Sananda.